So thank you all for sticking to this breakout session. I think probably the best way to define this versus the next one, and you guys are welcome to go back and forth, I promise. This one is mainly, I'll be talking about first-line therapy. So, induction therapy, transplant, and so forth. Dr. Silberman next will be focusing on, after the myelomas had come back, so relapsed myeloma, how to manage that. But obviously, at the end, I'll make sure there's time for questions. I'm happy to answer questions about anything that I can. Myeloma related. Like the solar eclipse, apparently we all missed that just went by, but everything else I can talk about. Yes, indeed. So here I missed it. I'm sure in Seattle we wouldn't have seen it anyways, I'm guessing, right? Not on a day like this. Here are my disclosures. So again, I will kind of, you could maybe also call this, what your doctor should be thinking about when they're treating you is kind of the way that I look at it. So I'll kind of focus on the doctor's approach to myeloma, and so I'll kind of sprinkle in kind of my commentary as we go. So some of you may have heard of NCCN guidelines. NCCN is a National Comprehensive Cancer Network. So Fred Hutch is one of the centers that's the founding member of the NCCN committee, and they basically come up with how best to treat any type of cancer, multiple myeloma being one of them. And I know you don't have context, but for all the other kinds of cancers, typically there's like 1 or 2 or 3 options. Here, if you see it says primary transplant, primary therapy, and there's like 30 options between this page and this page. So it's very, very complicated. And one of the reasons we'll talk about why I do encourage patients to always get that second opinion or meet me, even just by Zoom, is because this is very complicated. Even for me, this is complicated, let alone for a community oncologist who treats every kind of cancer, not just this. So things that come through my mind and really anyone should think about. So question number 1, should I use a triplet or a quadruplet? Some of you have heard these words, some of you haven't. Dr. Cowan briefly alluded to this in his talk. A triplet is 3 drugs including dexamethasone. A quadruplet is 4 drugs including dexamethasone. So the dex all of us hate, myself included. So if you exclude the dex, a triplet now becomes 2 drugs. A quadruplet becomes 3 drugs. So that's question number 1, triplet or quadruplet. The answer typically is quadruplet for patients who are, bound for transplant. We'll talk about that. Can I tailor the dose? So we will definitely talk about this. A lot of in the Q&A earlier, a lot of you described side effects that come up with treatment. Revlimid is famous for side effects, unfortunately. And so can we tailor the dose for you? Because at the end of the day, I'd rather have a patient stay on the drugs and the therapies at a dose that works for them than have so many side effects they have to come off all treatment, because then I haven't done them any favors. Question number 3, should I refer you to a transplant center? So again, Fred Hutch, Swedish are always just your examples here. There are other, the Compass does some transplants, I think, in Eastern Oregon. So there are definitely transplant centers out there. Should I talk about transplant? And then this came from the Q&A, and I can talk about it later. If no transplant, should we try to collect and freeze the stem cells? And question number 4 is what type of maintenance? So almost all of you in the audience have heard of lenalidomide before, Revlimid in one way or form. Is that our best bet, or should we do something different, or should we add a drug to it? So going through each drug kind of one by one here. So triplet versus quadruplet. So again, these are all triplets here. So you can see the DEX is here. We're terrible with our acronyms. Why is the D capitalized there but lowercase there? Anyone's guess. The BOR is bortezomib, is the same as a V, which is Velcade. So again, because all drugs have 2 names, right? So this is terrible, and we don't make this easy, and I will openly acknowledge that. But these are some triplets. So Cybor-D is a triplet. VRD, many of you may have had or may be familiar with us with bortezomib or Velcade with lenalidomide. Someone had asked earlier about Kyprolis, carfilzomib, that's here. And the newest kid on the block is Dara-RD from the Maya study, which is daratumumab, frontline with lenalidomide and dex. And then quadruplets are basically 3 drugs plus a CD38 monoclonal antibody. So daratumumab is there. So Dara-VRD is what I typically use for most patients. But also, for example, those at Kaiser might get ISA-VRD. For some of our high-risk patients, Dara-KRD or ISA-KRD may be helpful. So triplet versus quadruplet, my main point is I don't care as long as there's a monoclonal antibody in there. So this is one of the biggest things that we are trying to change about how myeloma is treated frontline. And I think many of you in the audience may have been treated before. This was a common occurrence. Unfortunately, I think too many of our community docs don't realize that the times have changed and are doing this. So we're working on educating them as best we can, but all of you, feel free to spread the word to patient support groups, to your friends, to your doctors, being like, hey, by the way, did you know that you should be using this frontline now? Because you should. So what are these drugs? Daratumumab and isatuximab. They are CD38 monoclonal antibodies. What that means is that they are antibodies that basically they bind CD38, which is found on myeloma cells. They just stick to it, and they either kill the cell directly, or they act as a flag to bring in the other immune cells that have been unable to recognize that the myeloma is foreign. All of a sudden, the immune cells realize something's wrong, and they kill it. Most centers do daratumumab. So daratumumab is FDA approved for first-line therapy. Isatuximab is not. However, Kaiser uses ISA frontline, and this might change. Both may be available first line soon. Why do I bother adding Dara or ISA up front? So Dara, again, is Darzalex or daratumumab. ISA is Sarclisa, isatuximab. The biggest reason I would say actually is number 2 here, but I'll talk about the first one, deeper remission. So we have higher rates of complete response. That's remission where the AMP spike's gone. MRD negativity I can talk about. I purposely didn't talk about it that much in the slide deck, so a lot of people get into deep remissions. What I think is most important in the front line, because an induction is only a couple of months no matter what, right? And then we're either going to transplant or do something different. These remissions are fast. With CyBorD and VRD, and many of you might have had this, it typically takes about 2 to 3 months to get your first response, which is to get the numbers down by at least 50%. With Dara, I've had patients where within one cycle, their light chains have totally normalized, because it really works very quickly. And so I think that for our patients who are really so scared, right, all of you have been here before and know this, that's a big deal. For patients who have bone pain, for patients who have neuropathy, for patients who have kidney issues, getting into remission within 3 weeks and not 3 months is a big deal. And that's one of the biggest reasons to add these. And then obviously this is the biggest benefit kind of long-term, is that patients do stay in remission for longer. The word we use for that is progression-free survival. Again, everything about cancer is weird. For anyone in like the technology field, progress is good. In myeloma, progress is not good. So progression-free survival is how long does it go before the myeloma starts to grow back again. So you get longer PFS, longer progression-free survival with this. Dr. Cowan already mentioned this, so I'm not going to go into many details. I'm going to save time for questions. But in brief, this is the phase 2 study that we ran that helped prove that Dara-VRD, so a quadruplet here with daratumumab, was better than VRD, which is a triplet with just with no CD30 monoclonal antibody in the front line setting. And basically here, again, these Kaplan-Meier curves, doctors are obsessed with them. It's kind of difficult to read, but you can see here that if you basically look at the 4-year mark, the second vertical line is at 4 years after randomization. You can see that 87% of patients in the Dara-VRD arm were still disease-free. So basically only 13% of them had the myeloma come back in 40 years, versus in just the RVD arm, instead of 13, that was 30%. That's a very big difference. There's some caveats. This study used doublet maintenance for everybody, and we'll talk about that. I typically use just Revlimid for most patients. But I think even if you say that just the beginning, MRD negativity, which again, we can talk about if you're interested, MRD negativity rates were much higher even after 3 months. So after MRD negativity means basically that even with the best technology available in the US in the year 2023, we cannot see the myeloma anywhere. Doesn't mean cured, it means we just can't see it anywhere. Not even 1 in a million cells are myeloma, and almost a quarter of patients were able to get there only within 3 months of treatment, which is amazing. What about for patients who don't go on to get transplant? Because again, transplant is an evolving field. 10 years ago, all we had was transplant. 40 years ago, Fred Hutch was one of the first centers in the world to do transplant, if not the first. But the fields are evolving. A lot of patients don't want transplant or can't get transplant, or medically we feel that transplant, the risks outweigh the benefits of transplant. Even in those patients, Dara-RD, which is called the Maya, this was called the Maya trial, did really well here. So I think here this is difficult to see, and it's kind of small text, but the one in the middle here is actually overall survival. And you can see here, I can barely read it myself, but at the 5-year mark, 5 years into treatment, these are patients who are older, maybe frailer, didn't get transplant. At the 5-year mark, 67% of them were alive who'd gotten Dara-RD versus only 53%. 53% in the patients who didn't get Dara. So that's really a big deal. This is the one I love the most. Because it's one thing to say that, yes, patients are going to live longer, but I also want them to live better and live longer, right? You don't have to choose between them. And so here, you can see that they actually looked at pain scores over time. And you can see the blue line, there's a Dara-RD, lower is better. You can see that almost immediately this group started to have lower pain scores, and it got better and better and better. So again, what I'm alluding to earlier, adding a CD38 monoclonal antibody, patients are in remission faster, and they feel better faster. So in terms of triplet versus quadruplet, with that in mind, I always want to include daratumumab or isatuximab or DARA. For patients who are relatively healthy, under 75, I tend to use a quadruplet regimen like this. I won't talk about amylase that comes up. For patients who are older or less healthy, they have a lot of, for example, other heart issues, or the Velcade can cause neuropathy. So if you have a lot of neuropathy at baseline, I may say it's not worth making the neuropathy worse. So DARA RD is fine to start with. Importantly, I think it's not. These drugs work so well with DARA VRD. With DARA VRD, 80, 90% of patients have a response to therapy. So you don't need. I always tell my patients, you don't need to be soldiers about this, right? Like, this is a give and take, because a lot of our doses, we can adjust the doses, we can make the treatment more patient-friendly for you to just kind of make your quality of life better. So I would say it is completely fine if you start with a quadruplet and drop the Velcade because it's causing neuropathy, or the Revlimid. I've had this happen, right? All of you know is often very expensive, and they drop it, and that's okay. If you drop the steroids, so we'll talk about the dexamethasone causes a lot of side effects, including some of our research through HealthTree, through the Cure Hub that you just heard about, shows that dexamethasone can predispose patients to cataracts. So we're trying to use that research to help get the field to stop using dex. I should add that dropping dexamethasone is totally fine. My personal style is I try to drop the dex within 1 or 2 months. It's helpful in the beginning because it helps with pain control. Many of you who have been on it know it gives people that kick of energy. It's just sometimes helpful. And it does bring the myeloma numbers down quickly, but after that first cycle or two, they're not adding that much at all. So again, that was question number 1, triplet versus quadruplet. Question number 2, how do I make the dose friendly? Again, what I alluded to in the Q&A is true. Revlimid is the same. It's not dosed on patient's height or weight or anything. We just give everybody 25 milligrams of Revlimid to induction. We give everybody 10 to 15 milligrams of Revlimid during maintenance, no matter what their personal history is, no matter what their weight is, no matter what their height is, and that's unfortunate. And I think in real life, we really should adjust it. So, daratumumab and isatuximab can sometimes cause infections, and so we can sometimes tailor the dose or use other medications to prevent side effects. Bortezomib Velcade can absolutely cause neuropathy, so that's something that we should definitely do and make sure that we're aware of. I will say that a lot of docs in the community use Velcade twice per week. I'm not going to ask anyone to raise hands, but I bet many of you were getting Velcade twice per week during induction. We don't do that anymore. We really shouldn't be doing that anymore. The trials do it, unfortunately, and we're working on fixing that. But once a week works just as well, and less neuropathy. This is new. Again, you're going to hear, for some reason, not for some reason, it's because of me. There's a lot of stuff about eyes in my talks today, and the survey that you guys will be doing afterwards involves ocular health in terms of eye health. Velcade can cause blepharitis or styes. And I've had some patients be like, every month they're getting styes in their eyes, and you had them to you. Yeah, a lot of local docs don't realize. Did your doctor know right away? Or you had us the whole time, right? Okay, so hopefully one of us knew what was going on, but a lot of docs don't know this, and I think it's important to educate them this is a real side effect. Revlimid, everyone in this room knows Revlimid has plenty of side effects. We can lower the dose very easily if needed as low as 2.5 milligrams. And then financial toxicity is real, and there are a lot of resources that any of us, including Fred Hutch, the drug company that makes it, LLS, the Leukemia Lymphoma Society, can help with to make this affordable. So Dex, again, all of you are familiar with this in terms of how to make this treatment more personalized. This is what the trials go. In my mind, if there's any issues with this dose, 40 milligrams, so 10 pills once a week, or 5 pills once a week, or 5 pills twice a week, I go down to 20. And if that doesn't work, go down to 12 or stop. Most of us, I would argue, are over-treating our patients with dexamethasone for longer than they need. And I'm trying to be personally at the vanguard of changing that. So hopefully in 5 years, this talk will look different, but we're working on it. Thanks to the help of patients like you who are helping to educate us about what we should be doing differently. Other tips that come in mind for patients on dexamethasone, just to be able to stay on and deal with it. So again, sleep hygiene is very important. Taking it with meals is helpful. Steroids for some patients really cause leg swelling, so diuretics or water pills can help. Leg elevation can help. Exercise came up a couple times, including Dr. Silberman's talk. That's super important because dexamethasone absolutely impairs proximal muscle strength. Some of you may know, noticed that basically your upper arms and your thighs kind of start to feel flabby with dexamethasone. That's real. That's 100% real, and that's 100% the dex. And so exercising and stopping the dex helps with that. Dex, even once a week, can put people at risk of osteoporosis or high blood sugar, so all when primary care doctor matters. Again, eyes, I'll keep talking about, that's a big deal. And then, of course, a patient support group. So for all of you here in the Seattle area, right, the myeloma fighters are a good example of a patient support group that I think are really helpful to hear that other people are going through what you're going through and giving you tips on how to deal with the decks. Transplant or no transplant, this could be, I've given hour-long lectures about this. Right now, I'll try to do it in 2 minutes. The idea with transplant, right, many of you are familiar with this, and I'm happy to talk about it afterwards. Transplant has all these different words here. So autologous stem cell transplant, stem cell rescue, and so forth. The big point with transplant, as all of you know, with allotransplant, when people hear the word bone marrow transplant, they often think about, kids with leukemia, with getting a donor. This is not that kind of transplant, as some of you know. It's an autologous transplant. It's your own cells, and the cells aren't doing the heavy lifting. The chemo is doing the heavy lifting, right? It's a very high dose of chemo, obliterates the bone marrow. Everything it sees, good and bad, it gets rid of. And the idea with the stem cell transplant is to rescue you from the side effects of that high dose of chemo. So again, it kills, this is actually, studies have shown that it kills 99.999% of what it sees in the bone marrow, good and bad. And we just kind of help with we pre-collect your cells, stem cells are given back afterwards. So Dr. Cowan talked about this, so I'll go quickly just in the idea of saving more time for questions at the end. So I don't think he actually showed this slide, right? So what's controversial, absolutely, there were two studies. There was a big French study and there was a big US study that Fred Hutch was part of that shows that patients who get transplant are in remission for longer. But here, they have tried, Fred Hutch has tried, people have tried for decades to show that transplant makes people live longer. Transplant has never been shown to make people live longer. Here, for example, there's a Kaplan-Meier curve. You can see here that the two lines are the same. So if you look 5 years, 6 years, 7 years out, the same amount of patients are alive whether you get transplant or not. Why, I should say, is because people can get transplant when the myeloma comes back. In the modern era, right, we have CAR T, we have bispecifics, all the cool things you knew about. So I would say that if you're going to do transplant, do it early, because after this point, I would say we have better tools available. So what do I talk about regarding transplant? So I talk about other health conditions. I think a lot of patients get scared when they hear the word transplant ineligible. I think we do a poor job as a field explaining what that means. Transplant has risks. It's a mega dose of chemo. Like the highest dose of chemo we ever give to anybody is for multiple myeloma during a transplant. And had a lot of side effects. And there's like a 5% risk, I often quote, of life-threatening issues or even death from transplant. And if I just said transplant's not making you live longer, we really have to talk about with each patient, do the benefits outweigh the risks here? For some patients, it doesn't. Other thing here is that for patients, and you kind of alluded to this, transplant, that study, the determination study, was only of patients under 65. So for patients 65 and older, there technically is no data showing that transplant is better than no transplant. So it's a very nuanced decision. And then this matters a lot, right? Are you willing to come to Seattle for 2 months? Do you have a caregiver? Fred Hutch does not require a caregiver for transplant. Most centers do around the country, actually, but that can be a big barrier. And then is this temporary dip in quality of life important? So it's a tough decision. Talk to your doctors about it. I'm obviously happy to answer questions about it in general. This probably comes up for many of you. What maintenance do I use after transplant or without transplant? So basically, the point of maintenance is some is better than none. The idea is that if you compare patients who are on observation after induction therapy or transplant, patients who are on some form of therapy for the long haul do actually live longer. That has been shown. Unlike transplant, maintenance has been shown to keep people both in remission for longer and actually help them live longer. As all of you know, we often do continue maintenance until progression. This is different, right? Many of you are on Revlimid for years or maybe on Velcade for years. And again, here, maintenance therapy does help people live longer. Can we stop maintenance therapy? Does it have to be indefinite? So I would say, and I alluded to this in the Q&A, if you're having side effects, it is not worth suffering. I tell my patients, this is the chance where you're supposed to feel like you can rebuild your life and live your life. Easy for me to say that, obviously harder to live it, but this is the phase where I want people to travel. I want them to travel internationally. I want them to go see their grandkids. I want them to do stuff as they can. And if this drug, the Revlimid, is interfering with your quality of life or draining your bank account, not worth it. We can find something else that works. So that is something that we really talk about. So if you're having issues with it, I don't think maintenance is worth it. There are ongoing studies that we can maybe talk about, or maybe for round 2 roundtable. None of us talked about MRD that much during this morning's or this afternoon's talk. That's a whole separate day's worth of topics. But MRD negativity, again, in a nutshell, is that even with the most modern technology available in the US, which is actually a company here in Seattle called Adaptive, or Mayo Clinic has a flow-based assay for this. You can't see any myeloma anywhere. Doesn't mean cured, but it means that not even 1 out of a million cells in the bone marrow are the myeloma. For those patients, if they're MRD negative on 2 separate bone marrows, I can talk to them about stopping maintenance entirely. This is an evolving topic because it's controversial, because if I just said that Revlimid makes people live longer, who am I to tell someone that I'm going to stop it for you, even if I know it might help you? And it's a nuanced, evolving discussion. So Revlimid, we kind of talked about it in the Q&A. So, it's often 10 to 15 milligrams. If after transplant, typically start it within 3 months. If no transplant, often some people take 6 to 8 months. I normally do 6 months and then move to just Revlimid by itself. And then all of you know this in the room. So all sorts of issues. So this was not my idea. So Revlimid is lenalidomide. It's a cousin of thalidomide, right? The birth defect drug from the 70s. That's why they treat you like you're some sort of a criminal to even ask for it. That's why it's so expensive. That's why, for some of you are nodding, they ask for the pregnancy tests again and again and again and again. That's why they cannot ever give you more than 21 days or 28 days at a stretch. It's because of all of these restrictions that the government placed on Revlimid being prescribed. Not always practical. Many patients have side effects. Some patients have kidney disease, and Revlimid's not an option, in which case Velcade is fine. There is this risk of second cancers. This is controversial. So I would say the reason it's controversial is because Revlimid absolutely has been shown to make people live longer. So if you do a study and you see that someone's getting another cancer higher rates with Revlimid, is it the Revlimid, or is it that they're living long enough now that this other cancer becomes a problem? And it's really, really tricky to kind of unravel part versus parcel. I do think the signal is real. So what I do tell my patients, transplant or no transplant, is take your primary care doctor seriously, right? I think during induction, I often end up being the person's main physician for everything. During maintenance, whatever the primary care doctor says in terms of cancer screenings, I would do. Dr. Silberman brought up the 38th parallel or whatever she said, right? For all of us here in the Portland, Seattle area and above, a lot of us, I think, underestimate how much skin cancer can happen, right? We assume it's cloudy for 6 months a year, whatever. Skin cancer can happen. So I add, in addition to the normal primary care screenings, I also always tell my patients, have a dermatologist or your primary care doctor do a head-to-toe skin exam once a year, because most of the cancers, if they happen to Revlimid, are just skin cancers that can be plucked right out again. Doublet maintenance. Dr. Cowan briefly touched on this topic. So not using just Revlimid, but Revlimid plus something. So that's often Revlimid plus the Velcade every 2 weeks, or the Dara, the Darzalex, once a month. When would I do that? So I often do it for patients with high-risk cytogenetics. So this is where the bone marrow biopsy is helpful. Most centers in the country, academic centers, are doing this now. So for patients who have high-risk cytogenetics, we typically give them 2 drugs afterwards. There hasn't been randomized data showing that works, but there have been pretty good data showing that does keep people in remission for longer than one might expect with a single drug. Some physicians use all 3 drugs, so including the dexamethasone. Again, I would say no dex in this setting for maintenance, because dexamethasone has a lot of issues, including fatigue, cataracts, and so forth. But I think it is reasonable to use, for example, Velcade plus Revlimid or Dara plus Revlimid. And why? I can be talked about this. So it helps counteract high-risk cytogenetics. So if you were to use just Revlimid after transplant for someone who has deletion 17p in the myeloma cells, something high risk, typically transplant might work for 1 to 2 years. Here, this is data out of the Emory group in Georgia. Typically, you get 3 to 4 years of mileage if you use 2 drugs, which is about the same as a patient with standard risk cytogenetics might get after just Revlimid by itself. I'm moving quickly on purpose. I want to take time for questions. And I know I talk quickly at baseline, so at the end, feel free to have me come back to anything. The Zometa, we kind of talked about. Dr. Silberman alluded to this. So I typically say 2 years altogether, no matter what. I don't stop after transplant immediately. I kind of keep it going. My style is monthly for a year, and then every 3 months after transplant, or every 3 months for a year, just around that 2 years. I brought this up in the Q&A. So for some patients, and there is evidence for this from the IMWG, from our big myeloma international working group that kind of talks about this. For patients who had a lot of fractured or lytic disease at baseline, I think it is very reasonable to do scans once a year, as long as a patient doesn't mind. That can be a whole body CAT scan head to toe. That can be a PET scan. That can be an MRI. Why? About 10 to 15% of myeloma relapses are what we call oligosecretory, which means that the AM spike or the kappa or lambda light chains don't rise that much, if at all. but foot starts growing into bone. It is possible. It's uncommon, but it's possible. And typically that happens in patients who had lytic lesions or had bone spots at diagnosis, and the myeloma tends to relapse in the same way when it decides to come back. And so for those patients, I do try to do once a year scans if I can. And I do keep checking the myeloma numbers. So I sometimes do space it out to every 3 months for patients who are doing quite well, but I do think that makes sense to stay vigilant for it, because if the numbers start to rise, we have many excellent therapies now. For most of my patients who are having a relapse now, I don't need to ever talk about second transplant because I have so many other good therapies available. CAR T is coming and so forth. And so it's not something to be scared about. Patients get worried, they get really nervous about these tests, and I would say there's a big difference between looking for trouble and have trouble looking for you, right? You guys have heard this before. Most of my patients, I tell them, look, it's better to go look for the trouble. Because if this amp starts to rise again, I know it sounds scary, but we will have caught it supremely early. We'll be ready to move when it happens. So 15 minutes. Okay, I did it. Same code as before. I will stop there, and I'm happy to answer questions about anything in myeloma. I will not try to govern the mic.
They always talk about a second cancer after transplant, possibly getting a second, and it could, what I've heard, it's skin cancer. Is there some truth to that?
It is. So it's really also difficult to unravel. Is it the transplant that's putting people at risk of second cancers, or the Revlimid after the transplant? It's probably both. There have been some studies from the UK that show that both patients who undergo transplant and patients who have transplanted with Revlimid have slightly higher risks of second cancers than those who don't. Yes. So the short answer to the question is yes. It's typically skin cancers, probably over half. I was part of our big international Center for International Blood and Marrow Transplant Research. We published our research last year. I was part of that team. About half of the cases were skin cancers. It's important to note sometimes they're not. Sometimes patients do have scary cancers that come back, like for example, leukemias can sometimes develop from this. Mm-hmm. The biggest takeaway, and I tell every patient this who's nervous about Revlimid, is in that study, and if you ever see me or follow me on Twitter or find HealthTree can find me afterwards, in that study, even for those patients who got secondary cancers that we said were from the Revlimid, the number one cause of death when you actually look down the line was still the myeloma, if that makes sense. Ooh. So it's important to remember that at the end of the day, the myeloma is still the biggest threat that our patients are living with, that maybe you're living with. And I would say I wouldn't withhold the therapy that you think works because of a theoretical risk that may or may not happen down the line. Mm-hmm. It's an excellent question.
I hear most talk about Revlimid. I'm on Pomalyst. Are they the same? Or I mean, in terms of the words you're saying, are they kind of the same?
It's an excellent question. So no, actually. So I think Pomalyst is a better maintenance drug for sure. Do you know, if you mind sharing, was it because the Revlimid was causing issues of some way or form?
They just put me straight on that.
And were you on Pomalyst before transplant or before? No. Okay. So yeah, so I think Pomalyst is a good bet. A lot of insurance companies won't approve it for maintenance, which is why I don't do it routinely. Because as all of you know, Revlimid and Pomalyst are both made. Everyone from industry left? Just making sure. If I see any BMS faces here, I'll smile at them. But yes, they're good drugs, but they're extremely expensive.
I see.
As all of you know this. So what I was with Pomalyst is Pomalyst probably has less of a rash than Revlimid does. And importantly, there was a study from the Dana-Farber group, Dr. Sperling, earlier this year or last year, that probably, at least preclinically, like in a petri dish, like in just not human trials, but preclinically, Pomalyst probably doesn't have a risk of second cancers the way the Revlimid does.
I see. Great.
So yeah, I would say if Revlimid is causing issues for patients, I often then try to appeal to the insurance company and say, look, Pomalyst is a better bet. Pomalyst is also a pill, easy to use, still expensive, still annoying. The pregnancy stuff doesn't go away, unfortunately. But I think it is a better drug, and I hope for a scenario where Revlimid is just gone. I will not shed a tear for Revlimid when it retires from business.
Thank you.
Uh-huh. Yeah, go ahead, Johan.
After I had my autologous transplant, I asked the transplant team, was it successful? And they said, we can't answer that yet. And now that I see about maintenance and all everything else that can go wrong. Is that probably why they didn't say it was successful?
It's a good question. It's really difficult to say how, yeah, because the best way to tell how well something works is, with this kind of a study where you follow someone for 3 years and see, or 6 years and see what happens. Obviously, 6 years later, you know what happened. Either it worked or it didn't work. In real time, how can you tell what are early indicators that treatment is working or not? Maybe, I'm going to twist your question into a question about MRD. So again, some of you, maybe I'll, for show of hands, have any of you guys heard of MRD before?
Yes, from you.
From me, okay. So I see a lot of hands. Okay, that's great. Okay, so we can definitely talk about that because that comes up every meeting I go to is a debate about how we use MRD. And there's two ways to think about MRD. There's ways to think about MRD as an endpoint, like, oh, I achieved MRD negativity at this level, that's good. And there's a separate question of MRD as a middle point, meaning to guide decision making. Let's say, oh, my MRD level is this, I'm negative versus positive, therefore I'm going to change what I do and do this. That second paradigm is not really ready for prime time. I mentioned that in some patients, based on recent data published last year by Dr. Costa at Alabama and colleagues, that if someone's MRD negative repeatedly, there's a rationale and there is evidence to suggest stopping the transplant, stopping the Revlimid maintenance. You're asking more here, can you use MRD as an endpoint to say, hey, the transplant worked or didn't work? It's tricky. It's tricky for a lot of reasons. I think one, because the transplant, the melphalan, takes time to work. CAR T works pretty rapidly. So for CAR T and bispecifics, I would say within 28 days, I can typically tell is CAR T working or not. Because you could probably tell, but the light chains come down dramatically, the bone marrow looks good, and so forth. Transplant takes time. And so achieving MRD negativity after transplant, probably about 40 to 50% of patients will achieve MRD negativity with a good quadruplet induction regimen plus transplant. The tricky part is even MRD negativity doesn't equal cure. One topic that Cindy was here, I think she's going back and forth from HealthTree brought up, and this comes up a lot. MRD, people hear this and they're like, oh, MRD negativity is good, and therefore I must achieve MRD negativity or else something is wrong. That second part is not true. Because it's possible for patients to have what we call an MGUS-like phenotype. The word for that, MGUS, have you guys heard of MGUS before? See, mostly nods. MGUS is the precancerous state. There's this theory that for some patients, and I'm going to, how can I hold the mic? I'm very effusive with my hands, but the idea is that you have your MGUS, that's a precancerous condition. There's a clone that becomes myeloma. You smack down the clone with induction therapy with daratumumab and then transplant. But that MGUS that's left behind is almost like a reptilian core, but the MGUS is not itself dangerous. It's just sitting there. And so some patients may be MRD positive for years. I've had one patient who's MRD positive for 6.5 years after transplant. It's a little scary because you're kind of like, oh, I kind of wish it was negative, but honestly, no. If it's not causing you problems, you probably have this MGUS-like phenotype. And so that's the tricky part is I don't know how to differentiate those patients in real time. So in your case, even if they'd done a bone marrow and even if they'd said MRD negative versus positive, I don't know that I would be able to say is it a failure or success or not. I would say, so bringing everything back together again, Dr. Hoffmeister at Emory has a nice slide of he says like, for when is transplant considered excellent versus not totally a failure. I would say that for most patients, I prefer to get at least 1 year of mileage out of a transplant, if not 2. So typically speaking, I would say if people get at least 2 years of mileage out of the transplant, meaning that they're staying in remission, I would say that transplant did what it came for. Some patients have what we call functional high-risk myeloma, where the myeloma does come back within a year of transplant. And if so, lesson learned to not use transplant on that patient again and not use chemo because we have other newer tools available. But I think for those patients, I would say that would be the only scenario where I would say if the myeloma came back within a year of transplant, we did the patient a disservice. The transplant didn't work the way I wanted it to.
Mine's going to work.
Yes, you're going to be fine. Yeah, no, it's and it's tricky because, so what it will say, so just so that comes up, so someone, that's happened. I've had patients where the myeloma have come back within a year of transplant. There have been a study, which I didn't put here, Karma 2 cohort A looked at CAR T for patients who had an early relapse within a year of transplant, and it worked as well for them as it did for anybody else. So, the kind of high-risk disease biology, when it comes back early, that's often a function of the chemotherapy not working. But we have newer tools now. CAR T doesn't care about chemo or not. It'll still work just as well. Go ahead.
If I've had a really severe rash reaction to lenalidomide even at a low dose, would there be any chance that Pomalyst would work instead?
I think it's worth a shot. We don't know enough about why Revlimid rashes happen. So Revlimid doesn't just act on myeloma cells, it acts on every kind of immune cell in your body basically to do something different. So in that scenario, I talk to patients about how bad is the rash. With Pomalyst, there's some studies that show maybe like a 40-50% cross rash, which means that maybe 50-50 chance you will get a rash with Pomalyst, 50-50 chance you won't. I normally stop the Revlimid, give it a month to wash out, and then try the Pomalyst at a low dose. And if that works, then great. And if not, Velcade is an option. But I will say that again, if the rash is annoying to you, we have Velcade, other options, or Pomalyst that are equally good. And I wouldn't feel like you have to have the rash to keep the myeloma in remission, if that makes sense.
Would you prefer the Pomalyst over the Velcade?
It's a good question. It's up to quality of life. There's a lot of decisions that go into it. I think the Pomalyst, is probably still a little bit easier for most patients, right? Because it is a pill that you can just take and then not take and so forth. The Velcade, typically I don't do it less often than every 2 weeks. So that is 2 weeks coming into clinic for that. On the flip side, depending on your insurance, right, and everyone here has a different scenario here, Pomalyst can be super expensive. And ironically, for those patients, Velcade may be much, much cheaper to come in and get the injection and forget about the Pomalyst. I think both are excellent maintenance options.
Anyone else have questions?
So let's see. We're in that transplant or no transplant. Where do you make that decision? And it's really difficult. Sorry.
I know. I'm sorry.
It's just scary. Transplant has, from what I know, there are a lot of physical effects afterwards. And then you look up there and it says doesn't extend life. How do you, trying to determine whether to move forward that way or not is a difficult decision.
It's extremely difficult. It's extremely difficult. And it's difficult because, when they wrote the study, I'm sure they were hoping for transplant to make people live longer. And I really do believe this is real, that it does not. Because we have transplant, if you are able to collect the stem cells and save them, you can use it for later. Or, again, by this time next year, CAR T therapy will be available for patients who are having their first relapse. So that might be another option as well. The way I ultimately describe it to patients is, their threshold. So I'll say two things about this. So it's a very obviously personalized decision. At Fred Hutch, we try to make it a little bit better for patients, but that sometimes makes it more complicated. So I am not a transplanter. Are you guys getting your care at Fred Hutch by any chance? Okay, right. So you probably met a myeloma doctor and a transplant doctor. A transplanter is a transplanter. Everything they see, transplant fixes. So they will talk about it like it's the only thing available. And the reason that we actually have the myeloma doctor see the patients first is to have them actually feel like, hey, like there are other options. Like I will take care of a patient whether they get transplant or no transplant. What I typically say about transplant is for some patients, they really want to be in remission for as long as possible. And for them, that extra, 3 months, detriment to quality of life or moving to Seattle is worth it for them. For other patients, the fact that they're still working or still staying active, they say, look, I don't want to deal with this. I want to keep doing what I'm doing. Some of you may know, for example, that like goodness gracious, the House Majority Leader right now was diagnosed with myeloma a couple months ago, and they keep asking, like, can he maintain his job? If he doesn't undergo transplant, absolutely, he probably will be able to maintain it. And so that's a big decision for things like that. What I would say then to kind of help you with this impossible decision that really will just be a matter of time, two things I would say. One, relapses tend to occur in the same way that the myeloma initially presented. So sometimes that helps patients because if a patient was only diagnosed with just some blood work that was off or a little bit of anemia or was smoldering that became active myeloma, one could argue, forget the transplant and just keep an eye on things. For the patient who had a very aggressive presentation with, lytic bone lesions and pain and fractures, I would argue for that patient, every added year of remission without that coming back is worth it. So that sometimes helps. The other thing I will say is no matter what the transplanters say, 10 years ago, probably only about 10% of patients who were offered transplant would decline it. Right now with my patients, it's about 60-40. So most patients still go ahead with transplant. I would say about 40% of my patients look through everything, talk through everything, and decide it's not worth it for them. And that number is probably going to go up with coming years of patients who decide to defer transplant. I encourage you to talk to other people here in this room or with the myeloma fighters and the people here, some of you I know have undergone transplant and so forth. It's a very personal decision. And we are the only cancer where you guys may remember back in the 90s, we used to do the same thing. Some of you may remember with breast cancer, right? This used to be in vogue until it was shown not to help. And so now 99% of patients with cancer don't get this. Myeloma is one of the few cases where we still offer it. And so that makes it just even more complicated. Does that help a little bit? I'm sorry, I know it's a really difficult decision.
It's just still, you were talking about the presentation, right? Like, so when Cheryl was diagnosed, she was kind of really more in the middle, right? Like she didn't present with a lot of lesions. It was kind of, we stumbled upon it earlier. So yeah, it's hard to say, exactly what that outcome will be, at first relapse, if that happens, right? Like, we just don't know. But yeah, it does kind of help.
Yeah,
It's just the more information we can get and the more we talk about it, the better decision we get to make. And you're right, it is a very personal decision. And, it's that idea of not knowing exactly what's right.
Correct.
That's the part that's really hard. Like there are some cancers where you're like, yes, this is what you do. End of story. That's the only way forward. It's kind of in the middle over here. You could do this, maybe this. So, yeah.
I agreed. And it's hard because, as you alluded, in 10 years we'll know. So they actually are doing a study, Cartitude 6. So by 2030 we will know because they're doing a study of CAR T versus transplant. That's what everybody wants to know. I want to know that too. That study is going to open next year. It's Europe only. I guess the Americans, like FDA, didn't like that study. So we'll know in 7 years. It's not going to help right now in this particular case. But I would say, no matter what decision you make, we got you. I'll put it that way, right? We have many new tools that are available for myeloma for surveillance, for maintenance, for treatment of relapse when it happens. When myeloma comes back, for most patients, it comes back as just numbers on a page, right? Even if you had a history of bone fractures and so forth at diagnosis, typically we're able to catch it with just the amp sweat creeping it back up again. So it causes anxiety, but nothing more than that when we treat at first relapse. So we're getting better and better at treating myeloma. I think, again, most of my patients do still use transplant as they view it almost as a kind of investment in their future to kind of, downtime now to kind of help time down the line. But that's changing. And probably by 2030, we won't be doing transplants. I mean, CAR T is going to win. I'm not at all in doubt about that. So I'm sure by this time, like a decade from now, we won't be doing transplant at all. But I think it's just what do we do until then, we don't know. Because right now, CAR T is not available for patients like in your situation at this point in time.